tell me that it will pick up both myself. Good afternoon. This afternoon we're going to tackle a big topic. It's a common condition in childhood because in general the neurotransmitters in a child's brain are basically switched to the excitatory path rather than inhibition. That is because a child's brain must grow. That is why epilepsy is very common during early childhood, but becomes less prevalent as the children grow older. So we're going to look at definitions, incidence, classification, etiologies, diagnosis, the influence of age on epilepsy, principles of management. Status epilepticus is going to be for self-study, and we're also going to just skim over treatment. And I'm going to show you some videos about non-epileptic events, but we're not going to discuss them in detail. And then I'm going to show you some slides on neurocutaneous syndromes, because they often are associated with epilepsy. As I've told you, a seizure is basically something that seizes a child. So that's any short clinical event. It can be a syncope, it can be apnea, it can be a breath-holding attack, but it's something that starts and stops. It has got a short duration. The difference between a seizure and an epileptic seizure is that an epileptic seizure is associated with hypersynchronous discharge of neurons in the central nervous system. They can both look the same, and because the brain can produce any number of different symptoms, you can really have a wide variety of ways that epilepsy then presents. So the definition of epilepsy itself is then 2 or more non-provoked seizures 24 hours apart. The critical thing about classification is that we look at where the seizure starts. Many people feel that we should rather look at the epilepsies as a concept rather than talking about epilepsy, because there are many different ways that they can present at different ages, and especially in childhood we can identify specific electroclinical syndromes. That means these are syndromes, or epilepsy syndromes, that has a typical age of onset, a typical type of seizure or seizure types, a typical prognosis and outcome, and sometimes even a very specific treatment. So that's why I would urge you to think about epilepsies rather than just epilepsy. In general, we divide them according to whether they start in a focal area of the brain or whether they are generalized, that means in both hemispheres. A generalized seizures is basically very shortly after the start of the epileptic seizure, it engages both hemispheres. Whereas a focal seizure originates in one hemisphere. So they may be either discretely localized or more widely distributed. But the point is that a focal seizure can quickly change into a generalized seizure. So this is a visual way of looking at a generalized seizure, and a focal seizure, one would say that this would start in this specific area and then stay in the one hemisphere or become generalized. The different types of generalized epileptic seizures are the ones that people generally know as epilepsy. And that's the one where you've got a tonic phase and a clonic phase, and it involves both sides of the body. Then there may be ones that's just tonic, some may be just clonic. Atonic can sometimes be difficult to differentiate from myoclonic seizures, because in atonic seizures you just suddenly lose all muscle tone, whereas in a myoclonic seizure you've got a sudden muscle jerk and then you may fall afterwards. Absence seizures may be typical, I'll show you an example of that, or atypical. Epileptic spasms are a very specific type of attack that is associated with a specific electroclinical syndrome, namely West syndrome. So, previously we thought, or we called focal seizures partial or complex partial. Complex partial then meant that the child had clouded consciousness, whereas now we just described the way it starts and whether it's motor or sensory or where in the brain it actually originates. So there you can think that if you talk about the frontal lobe, parietal lobe, occipital lobe, each one of those will have a specific way that they start. Your friend who had this strange metallic taste probably meant that was in the olfactory area of the temporal lobe and then spread and became generalized. The truth is, if you think about the symptom, then it can be epilepsy. So it can be mirthless laughter. It can be seeing flashing lights. It can be seeing spiders on the wall. It can be hearing voices. It can be like having an idea that you know exactly what the world is about. You know the solution to the world's issues and problems. And it's not 42, it's Dostoevsky who had that kind of seizures, that he had this clarity of the writer. So you can then see that obviously frontal lobes will involve high intellectual functions, parietal lobe, sensation, occipital lobe, vision, temporal lobe, emotion, hearing or smelling. So you can then see that if the motor cortex are involved, it may be in lateral clonic movements, or it may be tonic posturing, or it may be the classic Jacksonian march. Jackson was an epilepsy expert who described the seizures that started in the hand and then moved to the arm and then to the rest of the body. It's the so-called Jacksonian march. If it's the prefrontal cortex, then I don't know if you still remember the story. You've got the frontal lesions, and you've got a lesion, then you will look away and you will have an adverse head turning away from the cortical origin, the so-called fencing position. So it may also affect your speech. So there's a whole group of epilepsy, aphasias, syndromes which affect the speech, and it's from the very simple, the so-called benign epilepsy of temporal lobe epilepsy of childhood, with temporotemporal spikes, to something called Landau-Kleffner syndrome, where the children lose speech and then develop the epileptic seizures, which is a much more serious condition. The sensory epilepsies, the focal ones, may involve visual, auditory, olfactory, taste, balance, etc. If it starts in the temporal lobe, there may be autonomic symptoms. So it may be epigastric sensation, pallor, flush, sweat. There may be psychological symptoms, flashbacks, deja vu, jamawu. Do you remember the story of, you're sure you've been in this place, although not, and the reverse. You may have distortions. You may have the Alice in Wonderland syndrome, where everything seems small, or everything seems very large. You may have consciousness that's affected. These are just a few examples of drawings that children and adults made of the kind of things that they see, either prior or during occipital focal seizures. And you can see there that it tells you a little bit also about how the brain functions and how it sees color. So, epileptic syndrome is basically a category which has got something that you can replicate. That means there's a specific age of presentation, a specific type of convulsion, specific interequal EEG, sometimes specific etiology. Epileptic encephalopathies are basically epilepsy plus then developmental delay or regression. So that means that the underlying issue or problem or syndrome then causes the epilepsy, but it also causes regression in this child's development. So we've got two complementary systems. The one would be to ask what happens during the attack, and then we're looking at whether this will fit into a syndrome. So just to show you is why we're talking about the epilepsies rather than just epilepsy, is that the etiology may be structural, may be genetic, metabolic, immune, or unknown. The seizure types may be focal, generalized, or unknown sometimes. The epilepsy types may be focal, generalized, combined, or unknown. And that, the combination of all these different things, it can give you an epilepsy syndrome. So you can see that the number of permutations are basically unlimited. So, classified, as we've already discussed, according to clinical and EEG features. So, focal, generalized, undetermined, and in specific syndromes, where we also think about febrile seizures as a subtype. The etiology or the cause is divided into genetic, structural, metabolic, and then unknown. Some of you who read the old literature will still find this term cryptogenic, which was really difficult to understand, which meant we sort of knew what was going on but not yet. So now we just say unknown. So you can there see that the incidence of epileptic seizures are highest in year 1 of life. And then it slowly decreases because of the reason that I've told you. As you remember, incidence is basically the rate at which the water is added to the basin full of waters. Whereas prevalence is the water plus the water flowing. So this is just then per year. So you can see in the first year, the incidence will be maybe 120 in 100,000, whereas in the teenage year, it is 20. What it means is that you can be carefully optimistic if parents ask you, will my child outgrow me? Except if it's an epileptic syndrome with a known poor prognosis. Then you really need to be careful. So, in general, children will outgrow epilepsy. I think it's really important that you take cognizance of this slide, because if you look at first seizures, many people will have a seizure in their lifetime, maybe 5%, and then never again have a seizure. If you take a teenager and they party through the night and they have got all these different lights in different venues that stimulate them, and they don't eat breakfast, then they may actually have a seizure and never again, because there's been lots of provoking factors. So only 40% of people who has the first epileptic seizure continue to have a second one. What is the implication? The implication is that we should wait with treatment or medication unless we are sure that this child has an epilepsy syndrome that will continue and become something specific and with a known poor prognosis. Medicine are not without risk, especially valproate. In girls is a tricky medicine because almost all the medicines have got teratogenic effects, but valproate is probably the worst. It's been associated with autism, with developmental delay, with malformations, etc. So we don't want to give a medicine for something which just have got a less than 50% chance of recurring. Whereas once you've had a second seizure, almost 80% of those kids then will go on and have a third seizure and will probably then have epilepsy. You can still remember the definition, Nicola, of epilepsy being?
Two or more epileptic,
unprovoked epileptic seizures. So there are some risk factors that tell you that this child is more liable to have recurrent seizures. And that would be if there are focal seizures, if there are intellectual delays, and maybe abnormal interictal, that means between the epileptic attacks, EEGs. The risk is highest in the first 6 months, so almost 75% of them will recur, and most within a few weeks. So it can be reassuring to parents to know these numbers. It is the natural course during childhood. So, as I said, there's clear advantages to start after a second seizure. If the child has had a first seizure, then it's already important to talk to parents about safety issues. And they will always have a host of questions. Can my child do this? Can my child do that? It's important that you cannot really wrap children in cotton wool and prevent them from doing anything at all, because it's critical for their development that they must move around and they must be able to run about and so on. But the things that you need to be very careful of in a child with epilepsy or after a first seizure would be drowning. So obviously having a shower is better. And if you do only have a bath, always put in first the cold water and then the hot water, because if you have got a seizure and you fall into the scalding water, that's an issue. Open fires are always a danger. As you know, many of the children that we see from the poorer areas present with severe burn wounds. Obviously, riding bicycle in traffic and climbing trees is not advisable until you're sure that your epilepsy is well controlled. But in general, a child can do anything. Obviously, swimming alone is never a good idea for any child. So, if we look at the long-term remission rate, as I've shown you, there's a good chance of children outgrowing the epilepsy. And the good prognostic features would include a normal IQ, no focal neurological signs, few seizures, onset less than 12 years of age, and specific epilepsy syndromes, like the one that I told you about, that is one of the epilepsy aphasia syndromes, the benign Rolandic epilepsies. This is always a difficult question. Some seizure syndromes or epileptic syndromes, we know that the children will not outgrow them. Like, for instance, myoclonic epilepsy in the teenage years of Young syndrome. These children or teenagers need treatment for the rest of their lives. In others, it will depend. So around 18 months to 24 months after they've been seizure-free, 60 to 70% will have no further attacks, and it will make sense to withdraw it. I think if you withdraw the medicine, it should be slow. Most people would say 6 weeks to 3 months. And definitely it's not something that you should do if you're unsure about this. Obviously, you've got many different etiologies, and in the population that we serve, there are obviously many specific common etiologies like the infections, neurocysticercosis, hypoxic ischemic damage, which is more common than in the high-income countries, where malformations or genetic syndromes or degenerative illnesses or metabolic conditions would actually be more important. The one thing that has really changed the study of the etiology of the epilepsies is genetics. As you know, we now can look at the whole genome, or we can actually have an epilepsy panel that we look at these specific channels that's involved in specific epilepsy syndromes. So, the main message is that epilepsy is still a clinical diagnosis. And it's important that you learn to use language in a very specific and precise way. So much so that if you were a member of a bomb disposal squad, you would be able to give accurate instructions. You wouldn't use vague terms like maybe a little bit to the left or maybe the green wire. You would be very precise. So if you describe something, it really should start in a setting. Parents' first feeling or idea when their child has epilepsy is, my child is going to die. They lose track of time. They do not actually watch carefully what is happening. So if you reconstruct the episode, where was everyone? Was little Tabo or Johnny sitting or standing? Was he playing? Was he moving around? What happened next? Did he make a sound? What did his eyes do? Did you see jerking movements? What happened next? Was he unhappy afterwards? Was there incontinence during the episode? How long did it last? If they say 30 minutes, then you say, I'm going to count for you. 1001, 1002, 1003, that's 3 seconds. No, maybe it was shorter than 30. Because parents lose track of time. Did you take him to the hospital immediately? Did it stop by the time? How far are you from the hospital? So you get the idea. As I've told you, the sort of the thing that has changed our diagnosis, or ways to diagnose epilepsy or any paroxysmal event, are the cell phones that are almost ubiquitous now. Everyone can take a video and then show it later. But you should also tell parents to try and take the video until the end and for a little bit more beyond that, because that will often help us a lot. I think one of the things that people forget is that every test in medicine that we use has got a very specific sensitivity and specificity. And because you are a little bit sleepy now, if I would do your EEG would likely show some spiking waves in maybe, shall we say, 5% of you sitting here. If I take children in a school for children with learning disabilities and I do EEGs on them, 25% of them may show features suggestive of epilepsy, but they do not really have epilepsy. Often the parents and the teacher would say, but my child is just staring out of the window, I'm sure he's got absence seizures or he's got something. And it's actually quite easy. if you touch the child and they're back on, then it's unlikely. If it never happens, if a child is doing something enjoyable, it's unlikely to be epilepsy. So the EEG is not a test to confirm whether the child has epilepsy. It is when you clinically think there's a very high likelihood of epilepsy, and you either want to confirm a specific subtype of epilepsy or epilepsy syndrome, or if you're really unsure, then you can do what we call the gold standard, where you have a long-term EEG and at the same time take a video. When I show you some of the videos, you will see that that's exactly what is happening, because you will then have a paroxysmal event, and you will actually have a look at the EEG at the same time and see there's something changed during this episode. I think children who present with seizures mostly will need imaging, and if you need imaging, magnetic resonance is basically the first prize. It tells you a lot. You can pick up subtle malformations, migrational disorders, etc. There are some seizures which actually do not need the imaging. For instance, absent seizures in general do not need imaging. Why is it important to be accurate in diagnosing epilepsy? It immediately changes a child's future. It means it will be more difficult for them to apply for a driver's license. You are only seen to be cured of epilepsy if it's been 10 years that you've had a last seizure. So that's a significant number of years. It changes your, obviously, your ability to get insurance. It may change your self-perception in subtle ways. So there have been quite a number of infamous cases where doctors overdiagnosed epilepsy, basically because they didn't take the time to spend time with the parents on the clinical diagnosis, getting a good history. So the problems or the risks of overdiagnosis include unnecessary treatment, stigma and restrictions. The actual diagnosis are missed and neglected. Underdiagnosis may mean that you actually miss potential, and misdiagnosis may mean wrong investigations and treatment at prognosis. So why is misdiagnosis common? It's because we do not have a diagnostic test. We do not have a test that will say you have got epilepsy. It's a process of careful history, and there are many lookalikes. So many things look like epilepsy, and later on I will show you how much syncope can look like epilepsy. People have got these ideas that if you have got incontinence during an attack, it must be epilepsy. That's not true. They've got this idea that if you've got jerking movements, that must be epilepsy, which is also not true. And as I said, the EEG can be misleading when inappropriately used to confirm or exclude epilepsy. We've talked about the importance of the history, so it helps to describe whether the event was epileptic or non-epileptic, what the seizure type was, what type of epilepsy it is, what might be causing, and are there other problems. So seizures do not tend to occur in places that are convenient, and they are often modified by environmental factors. The people who actually are eyewitness to the seizures may have a preconceived idea. So they may say, I have got a certificate in first aid, so I know what epilepsy looks like, so it was epilepsy. So rather ask them, what did you see? The parents are often frightened. They think their child is dying. They often do not witness the whole event. So this is one way of describing then the epilepsy, the description, the seizure type, syndrome, the cause, and then if there are any relevant impairments, behavioral and emotional problems, and educational issues. So that means a full history, which will take some time. If we look at the influence of age on epilepsy, we're just going to look at 4 groups: the neonatal period, baby and toddler, childhood to early adolescence, and then adolescence to adulthood. So the main thing about a neonatal brain is that it's immature, so it does not localize the seizures so well. So the seizures can really be subtle. It's relatively easy, from what you described from your friend, that we can say he had a metallic taste in his mouth, and that's his temporal lobe. That doesn't happen in neonatal seizures. So you cannot say because this child's right hand was jerking, he probably had a left prefrontal. It doesn't work like that because the neonatal brain does not contain the discharge. So they may be fragmented and subtle, and often they are actually affected at the level of the brain stem. The cortex is relatively underdeveloped, and under 3 months of age we do not make a diagnosis of febrile seizures. It's often associated with congenital abnormalities, as one can understand, in the neonatal period. During the baby or toddler era, febrile seizures becomes to the fore because the central nervous system is more susceptible to the effects of fever, and specific syndromes may occur. It's also the start of myoclonic convulsions and status epilepticus, and that's often the start of some of these more serious epilepsy syndromes like West syndrome, Lennox-Gastaut syndrome, and the severe myoclonic epilepsy of infancy. In childhood, early adolescence, around 6 to 8 years, the typical time that absence seizures start, and I'll show you a video of that. They're easy to miss. Teachers often mistake the child with inattentive type attention deficit as having absence seizures. But if you just tell the teacher, just touch the child and see, they will often not respond to their name, but if you touch them, then they will respond. It's got a very specific stop and end. So you will have someone talking like I do and then suddenly stop in the middle of a sentence, may have eye roving movements, and then suddenly, as if you switch on the brain, then they are back again. Benign Rolandic epilepsy that I told you about, the children often typically present by having seizures at night. They would wake up, they would make a sound, the parents would see that the child has got movement first around the mouth, they seem unable to speak, they seem upset, and then they go on into a focal seizure which sometimes become generalized. Temporal lobe epilepsy, which can be of any type of color, starts during this time period. 9 years to adulthood, also a difficult time when primary generalized epilepsy or focal epilepsies become more common, often due to something that has happened and that has given the child a focal lesion. So, there are specific conditions that I'm just quickly going to go through. Neonatal convulsions, as I said, clinical manifestations may be subtle. There may be grimacing, apnea, sudden loss of muscle tone, chewing, boxing, cycling, nystagmus, eye movements, eye blinking, eyes deviating to one side. As you know, that neonates tend to be jittery, often those that are small for days or hypoglycemic. So there are ways to differentiate jitteriness from convulsions. Jitteriness are often sort of a higher frequency, lower amplitude, whereas convulsions are definite jerking movements, higher amplitude, lower frequency. With convulsions, you often have eye deviation, whereas with jittering it's not. If you take a jittery neonate and you hold them, you can often stop the movement, where it's not possible with convulsions. you may have an idea that the child's consciousness is affected. So you can think for yourself of different causes in the neonatal period that can cause convulsions, and that would include hypoxia, which is so common, trauma, especially intracranial hemorrhage in premature infants, periventricular hemorrhage. Metabolic, babies are prone to hypoglycemia, hypocalcemia, hypomagnesemia. Kern-icterus bilirubin can cause seizures, epileptic seizures. And then there are some rare conditions, and those are the pyridoxine deficiencies. Remember the mothers on IMH therapy. That's one cause of this very rare condition, which is quite treatable. And then some inborn errors of metabolism. So just to remind you, the inborn errors of metabolism are individually rare, but collectively they are common. They're basically based on the premise of that you've got a substrate that must be changed into something else, and you've got a metabolic process along the way. So if the enzyme that catalyzes this reaction is deficient, you will either have a deficiency on this side or a toxic substrate building up, and that can cause a seizure. So an example would be, for instance, galactosemia, if there's hypoglycemia, for instance. So bacterial meningitis is important in the neonatal period. If the mother has been taking drugs or substance abuse, or she is having withdrawal from sedation. So the second type of epilepsy that I want to discuss is the so-called West syndrome. So named because Dr. West described it in his own son. It's mostly in the first year of life, and often because people do not realize that this is a epileptic attack, because it just is a sudden flexion movement or just a subtle movement of the hands. These children are often go undiagnosed for weeks or even longer. So you have flexor and extensor spasms, and then you've got a very specific abnormality on the EEG. It's a totally chaotic EEG, and it's called the Hips arrhythmia, and there's developmental arrest or deregression. So it's really important that you try and diagnose these early. You get an association with some specific causes like hypoxia at birth or malformations or neurocutaneous syndrome, specifically tuberous sclerosis. But on the other hand, you also get a subgroup of infantile spasms which do not have a clear cause. Those are then called idiopathic, which basically means specific to the brain. So idiopathic, and as I said, this is that old term, presumed symptomatic, and then symptomatic. So these idiopathic subtypes do better. It may sometimes be very resistant to treatment, and this is one of the very few cases where the EEG actually guides treatment. So we will often start steroids and then recheck in 2 weeks whether the Hips arrhythmia is improving. If it's not improving, we will add a treatment, specifically vigabatrin or valproate. One just needs to remember that this one side effect of vigabatrin that we are very wary of is that it may cause constriction of the visual fields. So it may be difficult in a child with developmental delay to accurately assess that. Some of them, especially the idiopathic type, may improve, but almost 3/4 or more have got severe developmental delay. Autism is very much associated, especially in tuberous sclerosis. and they then can go on and develop another epilepsy syndrome, for instance like Lennox-Gastaut syndrome, which is the next syndrome that I'm going to discuss. That's one of the more common serious types of epilepsy syndromes, with a peak around 3 to 5 years of age, and it's got a very specific type of epilepsy symptom complex. It's a so-called jerk, stares, fall. Jerk, the myoclonic seizure; stare, the atypical absence; and the fall, the atonic seizures. So if you've got a child with that combination, you need to think of Lennox-Gastaut syndrome. Stare, jerk, and fall, they can often have or present in status epilepticus, and you need to be cognizant of the fact that the definition of status epilepticus has now changed. You've got 5 minutes of epileptic seizure, you have status epilepticus. Because previously we said give this medicine, wait, give this medicine, wait, and so on. And we now realize that if you have had a seizure for 7 minutes, you're going to go on and have a long-term seizure of more than 30 minutes. So we really need to be very active in stopping it. So as I've told you, stare would be the atypical absence, jerk, the myoclonus, fall, the atonic seizures, and they may also have tonic seizures. They are difficult to treat. They often need a combination of medicine. It's also maybe the time to tell you that if you use a single first drug, maybe 60% of children will respond. And then if you add another drug and you're sure of compliance and you've got the optimal dose, which is critical, milligram per kilogram, then maybe another 10 or 20% would react. But then the rest, 30%, would be treatment resistant. That means the child does not react to 2 drugs. So it's not so simple that if your child has got epilepsy, we can give drugs and we can stop the epilepsy. Unfortunately, that's not true. And in some children, you need the combination of 3 drugs. And then you also need to look at alternatives, which would include the ketogenic diet, or for instance, sometimes surgery, if you can specifically identify a lesion. The prognosis of Lennox-Gastaut syndrome is not good. Child with absence epilepsy is definitely not a small epilepsy. Previously it was called petit mal as compared to grand mal, but it can cause severe learning difficulty because these children may have these absences hundreds or even 1,000 times a day, where it's got a very specific start and stop. It's got a very specific EEG. There are 3 per second spike waves, discharges during the episode. They have got a reasonably good prognosis, and the treatment is usually quite simple. It's also one of the few cases where we will sometimes use the EEG to guide treatment. We've got a stop-stare-start sequence, short period of impaired consciousness, associated with staring, fluttering, and perioral movements, usually lasts less than 10 seconds, and you may have multiple episodes during the day and no recollection. The EEG are very specific, and the prognosis is mostly benign, with some that go on and develop generalized clonic seizures. Treatment, drug of choice would be valproic acid. Ethosuximide or lamotrigine is also affected. Tegretol may worsen the seizures, or carbamazepine, so be careful. Temporal lobe epilepsy often have this aura where the people will know this is coming. And as we said there, maybe in some of the functions of the temporal lobe, like smelling, it may start, or it may be actually associated with complex activity. But in general, critical thing here is that there's change in consciousness and that it's stereotypical. So if a mother phones me and say, Tabu, eat little Johnny with a knocky, then it must be temporal lobe epilepsy. And then I say, it's unlikely unless he does it 10 times and it's exactly the same and so on. So it's unlikely unless it looks the same. And I think temporal lobe epilepsy is probably one of the more overdiagnosed types of epilepsy, because people have got rages and they've got disturbances of affect, or they've got emotional lability, and then people would say, but this must be temporal lobe epilepsy. And one just needs to be wary. This epilepsy syndrome I've told you about, the so-called Rhodanic epilepsy, and that is the benign partial epilepsy with central temporal spikes, which is basically the EEG pattern. It starts typically more in early childhood, like 8 years would be a peak age. There's usually a pattern where it mostly occurs at night, so much so that some people would not treat it at all. But we've started to realize that it's often associated with other subtle learning problems or attention problems. So it usually starts in the face, tonic contractions, oropharyngeal muscles, so the children make these sounds. They may feel paresthesias around the mouth, and it's often, as I said, at night or upon awakening. Many don't need treatment because it's infrequent and it only occurs at night. And often they go into remission between 14 and 16 years of age. And we use the usual first line, and carbamazepine would be a good choice. Febrile seizures is going to be part of your life if you're a general practitioner, because it's quite common. It's one of the things that's really scary for parents, because fever often occurs at night time. If parents are far away from medical services and it's happened again, it's a big fear. And sometimes really difficult to persuade parents that simple febrile seizures are usually a benign condition that only slightly raises your chances of having epilepsy later on in life. So it's an acute symptomatic seizure, and it's quite common, as you can see, up to 4% of children. The importance is that 60% will not have a recurrence, but some of them can have multiple recurrences. It's in general got a good prognosis. Maybe 1% of people or less will have epilepsy in a lifetime, whereas if you've got febrile seizures, it does double the risk, but it's still a low risk. Anti-epileptics may prevent further seizures to some extent, but not the emergence of epilepsy per se. It typically occurs shortly after the start of the fever, in the absence of a central nervous system infection. So that is critical. That's the one thing we don't want to miss. If it's meningitis that causes a fever, it's not febrile seizures. It's a much more serious condition. And you may remember from what age neck stiffness becomes an accurate sign of meningitis. Can you tell me, Nabil? What age do you think? Maybe 18 months or so. But before that time, you cannot say, I've examined the child does not have neck stiffness, so he does not have meningitis, which means you should have a very low threshold in a child with fever and seizures for doing a lumbar puncture. Many people say definitely below 18 months of age. Others would say even below 2 years if you're unsure. But obviously, so if a child is running around, he's had a febrile seizures, and now he's 18-month-old and he's walking around, it's very unlikely that he will have meningitis. So it very rarely occurs before 6 months, and by 5 years most of the kids will outgrow it. There's often a positive family history. And it's also important to look for a family history of them having first febrile seizures and then later seizures without fever, because there's a very specific channelopathy that causes an epileptic syndrome called Jeff's plus, which means generalized epilepsy with febrile seizures, that then also has got other kinds of seizures afterwards. It's more common if there's a first or second degree family member, so these are just risk factors for febrile seizures. If the child has been in neonatal unit for a long time, if there's developmental delay, if the child has been in daycare, and also if it was a very high temperature. This is critical. We need to decide whether this child's febrile seizure was simple or complex. So simple means less than 10 to 15 minutes, one seizure per 24 hours, that it was generalized, and usually the simple types occur before 3 years of age. Whereas if it's complex, it lasts longer, it's more focal, there are more focal elements. The child may have transient paresis, TOTS paresis afterwards. Now, you remember the risk factors were for having febrile seizures. Now, these are the risk factors for recurrence. As we said, 30 to 40% can recur, and 10% can have 3 or more febrile seizures. The risk factors for recurrence would be onset below 18 months of age, low-grade pyrexia, short interval between the fever and the convulsion, family history of epilepsy, repeated exposure, that means being in daycare, and if there's complex seizures, especially if it's prolonged. So, always less than 1 year. If unsure, rather do a lumbar puncture, especially in the age group less than 2 years. If you do lumbar punctures and you only get positive results, you probably are doing too few, because it means you are probably missing a few. EEG has got a really limited role. It's not necessary to do EEGs for your management. It's only if it's really complex. So the main thing is we want to avoid the seizures. We want to terminate the acute seizures, and for that we would usually use the benzodiazepines. We want to prevent future febrile seizures and prevent epilepsy, but I think that is probably a little bit of a bridge too far. The benzodiazepines can be given in different ways. You can give it rectally, and then it's got a different dose. You can give it sublingually, you can give it intranasally. Lowering the body temperature is important, but tepid sponging really doesn't help, and definitely not putting the child in a cold bath, because what are you going to do? You're going to increase the core temperature because of peripheral vasoconstriction. Obviously, you need to treat the infection, you need to identify the infection. And the whole idea of prophylaxis is controversial, because the medicines that you use do have risk, and the one medicine not to use is phenobarbital. Phenobarbital is a good drug for neonatal seizures and maybe for a limited time in the neonatal period. It's very effective in status epilepticus, given intravenously, but using long-term, it has got a detrimental effect on children's development. So it's really important not to use that. So if you use something, you would use valproate or something similar. So risk factors for recurrence would be abnormal neurological exam, family history in young age, and complex seizures. So you can use valproate. You can have intermittent anticonvulsants. You can actually tell the parents this is the diazepam in the correct dose already drawn up. You keep it in the fridge, and if it happens, you give it in this way or that way. But that may be difficult. Intermittent antipyretics, I think it is important, but I think in general parents have got an almost irrational fear of fever, and they think that we actually should try and focus on fever, whereas the fever has positive effects too. As you know, the white cells are functioning better at a higher temperature. If the children uses less energy because they're feeling poorly because of the fever, it actually helps. So, when would you do an EEG? If you cannot sort out is this really epileptic seizures or maybe seroconvulsions, when is there a suppression of cognition? That means you give the child a task to see if this change in the EEG actually correlates with the impairment of consciousness. It can help in the management of status epilepticus, sometimes to diagnose a specific epilepsy syndrome. Can you quickly tell me, Marisa, what epilepsy syndrome has got a very specific EEG? Any one of two that we've discussed. Hypsarrhythmia and absence, hypsarrhythmia and West syndrome, and 3 per second spike waves in absence seizures. So, as I told you, we don't have time to go into the general treatment principles, but you first obviously use monotherapy, and you must make sure that you are careful. We often start, for instance, in the first week with half a dose, milligram per kilogram, and then you go to the full dose. One must remember that neonates and children under 2 years of age have got a higher tempo, so they often need slightly higher doses. You don't want side effects. You need to balance function together with the risk of the epileptic seizures themselves. So, especially valproate, if used in a very high dose, suppress the children. And if I have got to go higher, I would often use carbamazepine rather in a slightly higher dose, rather than valproic acid. Valproate has probably got the broadest spectrum. That means it suppresses the widest range of epilepsies, whereas carbamazepine is specifically very good in focal seizures, but they actually almost equipotent. Status epilepticus is self-study, page 563 in Bulgaria. Non-convulsive disorders, I'm going to show you some videos, also self-study. So now I'm going to show you just a few pictures of some of the neurocutaneous syndromes. So, Tahir, why is the skin important in neurological disorders?
Because it tells us that, for example, caffeine response is associated with.
But why in embryology? We both come from the ectoderm. Good. So, the skin markings of a specific neurocutaneous syndrome would then often be a marker of something wrong with the central nervous system. So, I'm just going to show you the most common ones, and neurofibromatosis type 1, type 2, or the type that's associated with bilateral acoustic neuromas, tuberous sclerosis, and Sturge-Weber syndrome. So, the clinical features of neurofibromatosis: the cafe delayed spots, coffee and milk, more than 6 spots, more than 5 millimeters. It's important to realize that they become more as the child grows. So if you see a few, you should follow the child carefully and see if they become more. And only later they typically have these axillary freckling. They may have subcutaneous or plexiform neurofibromas. They may have tumors of the cranial nerves, so that's why they need frequent examinations, endoscopies. They may have Lisch nodules, of which I'll show you an example, and they may have skeletal deformities. So this would be an example of the skeletal freckling. This would be cafe or lay spots, and here you can obviously see there's a very large one, more than 5 millimeters. This is the whole plexiform neurofibroma. There you can see an adult with the same thing under the skin. And these are the Lisch nodules that you can see in the iris of the eye. And these are examples of the abnormalities that you can see in the non-skeletal X-rays. So it may be associated with relatively large heads, hydrocephaly, optic gliomas, hamartomas of the central nervous system, increased incidence of malignant tumors, learning disabilities and attention problems, and epilepsy. Tuberous sclerosis is of specific interest because it's got a very high comorbidity with autism. So much so that almost 40% of children with tuberous sclerosis will present with features of autism. They often have these facial angiofibromas, and they may have hypomelanotic macules, so-called ash leaf spots, only seen with the woods land. They may have a shagreen patch, which looks a little bit like orange skin on the skin, and they may also have capriolet patches. So it's associated with a very strong family history because it's autosomal dominant, although 50% may be spontaneous. They may have cortical cerebral tumors. They may have renal abnormalities. They may have hematoma in the retina. They may have fibromas under the skin of the nails. This is how typical facial features look. This is another example. So if you see that in a mother, you know that you need to look in the child. This is the so-called hypomelanotic patch, or the ash leaf. This is the so-called shagreen patch. This is the periungual fibromas. And these would be the abnormalities that you would see on a brain scan. So it's one of the interesting, there you can see the tumors in the brain. It's an interesting condition for very long. Genetic therapy has overpromised and underdelivered by politicians. So now, for instance, in tuberous sclerosis, we are actually at the stage where we can influence at a cellular level something that's abnormal, or that is abnormal because of this genetic problem. So you may have two genes involved, tuberin and homartin, that actually is involved in the whole cellular cascade of making proteins. And there's a key protein called mTOR, which stands for mammalian target of rapamycin. And it's not necessary for you to know this, but it's just interesting because it's cutting-edge medicine. So mTOR is actually an inhibitor of cell proliferation. And homartin and tuberin inhibits mTOR. So if homartin and tuberin is defective, then obviously cellular growth goes haywire and you get these type of lesions. So we now can give medicines, the so-called mTOR inhibitors, that actually make these lesions on the skin, but more importantly, the so-called giant cell, giant subependymal gliomas vanish. And the most common type of drug that we use would be the type that we use for suppression, for immune suppression. There are different ones that we can use. So it's important that you know that there are treatments available that can actually treat this genetic condition. The drug's name is tacrolimus. So Sturge-Weaver syndrome often have got the so-called port line stain in the face, and it's associated with angiomata of the pia and epilepsy. So this is a quite dramatic way that neonates may present. And you can also see the same thing, same kind of nevus flammeus, and that is then associated with the abnormalities. So, is it running? Good. So we're back again with the epilepsy lecture, and I'm now going to show you some non-epileptic events And as we've said, these are then seizures, but not epileptic seizures, because they are not associated with hypersynchronous discharge in the central nervous system. So just have a look at this unit. Let's take a chance on VLC. And for the untrained eye, this may look very much like myoclonic jerks, but you will see that the baby is fast asleep and quite happy. Whereas you will see by contrast in the other myoclonic epilepsy, the myoclonic jerks of West syndrome that I'm going to show you, that it upsets the child, and the child cries after this. So this is the example of myoclonic or sleep myoclonus. This is a child with a breath holding attack. You may remember that we have two types of breath holding attacks. Any one of you? Cyanotic and the pale type. Yeah, so in the cyanotic type, so it would be typically an episode where the child is hurt, starts crying, and then hold his or her breath in expiration, and then maybe have some jerking movements during this hypoxic episode. So here you can see, fortunately without the sound, that the child is crying. And there the sound is. And you will see the child then stop in expiration, and if you carefully look at the limbs, you will see some slight jerking movements, so it may look very much like a seizure if you didn't have a clear picture and a clear clinical description from the start. So this is a cyanotic breath holding attack. So I'm going to show you a shuddering spell. Look at the child's face. You can see that this child has got an EEG concurrently. So this is a gold standard video telemetry with EEG. And you will see that jerky movements and the stiffness is typical of shuddering. But if you look at the child's face, the child looks quite happy. So this is not an epileptic seizure. Now I'm going to show you the German medical students from the 1980s, and you will see the instructor causing a syncope, but then how close it may resemble an actual epileptic seizure.
Let me show you some people syncopizing. So these are German medical students. They're in the 80s, as you can tell by the outfit. It's really easy to make yourself syncopize. Don't do it now. If you bend down on your knees and hyperventilate for a minute or so, and then quickly stand up and Valsalva as you stand, you will syncopize. So here's a healthy, normal German medical student syncopizing away. There he goes. He's taking a little longer than usual. There he goes. I want you to watch on each of these patients what their movements are like. So he's shaking. That's the myoclonus that reliably accompanies somebody who has transient ischemia to their cerebral cortex, or maybe the baby, we're not really sure. So she twitches a little bit. Those are a fine example. But you say, I can tell the difference. Well, you tell me if you can tell the difference between this guy. Watch this. Watch these movements. If you're seeing this yourself in the emergency department, I would argue this would be difficult to distinguish from a generalized tonic-clonic seizure, let alone.
Right. It's quite an American instruction. So that is an example then of a few cases of seizures that were not epileptic in nature. Now I'm going to show you a compilation of seizures, and I will move along. But you will see that they start off with one type, and they may use some of the old terminology. You can see that this guy obviously got a developmental delay, currently, and the important thing is to watch what happens first. You can see he's also got an EEG monitor. You can see the frontal adversive movement, the sound of the contraction of the muscle. So where did this start? Started with the movement, so it was frontal there. Left frontal, so he looked right, and then there were definite jerking movements, and then it became generalized. So it was started focal and then quickly became generalized tonic-clonic. And that sound that people often associate with epilepsy is the fact that his chest also contracts. The same tonic movement forces the air through his larynx, and that causes that sound. So that's an example of a generalized tonic-clonic. So we'll move along, and this is an example of a tonic seizure, which then just has the tonic component without the tonic. That was rather short, but it was mainly the movement of the head. So this is quite dramatic. You will see that this child is wearing a helmet, and these can be seizures that's almost impossible to control. And the main danger is that the children hurt themselves and cut themselves. So almost the most important part is them wearing the helmet. So these are atonic seizures. You will see the child happily loses all tone and just bumps his head.
Yeah.
And then he's fine again.
You have any more? No.
So it's a total atonic seizure. So it's yes?
Okay, isn't it easy for children to fake the atonic seizures? If they learn about it and they want to get attention or...
Yeah, one must just be careful. Children in general do not fake or malinger. That's one of the nice things about pediatrics. They can have symptoms due to psychological stress, which we call conversion, and then they usually have to have an example. So pseudo-seizures is something that we see, but we typically see it in the teenage years. And you must remember that children may have real seizures together with pseudo-seizures. But pseudo-seizures typically, if the eyes are tightly closed and there's a lot of deep thrusting and moving about, that's typical of pseudo-seizures. Real seizures, usually the eyes are not tightly closed. It's very rare for a child of this age, of 4 or 5 years, to have a conversion type of reaction due to stress. So they will definitely not fake it that they cut themselves.
No, but I mean, for instance, this atonic seizure where he just...
The key is in the helmet. If he didn't wear the helmet, he would be full of stitches.
No, but what I mean is like, he knows that he gets these seizures sometimes. That he could fake one when he doesn't want to do something.
To what? What will he get from that?
No, I don't know, but I'm just asking.
Yeah. No, I don't think that's something that we commonly see in children. They've got much better ways to get our attention.
And I'm just thinking of an example. Like, for instance, come from a bad household and the parents are fighting and he fakes a seizure so they can stop fighting.
You can think that, but then you will have the history. And this is Probably not a bad result.
Are these type of seizures associated with loss of consciousness?
Very short, yes. Very, very short. So this is a myoclonic seizure, just a single myoclonic jerk, and it may be difficult to differentiate.
These little jerks.
Can you see that may be difficult to
Then they start to progress. I notice how
differentiate between that and atonic.
his eyes get real glassy, and he'll kind of go into like this catatonic state. No, honey, please sit down.
So this is an example of a child with absence seizures, and look at the sort of, it's almost like a switch that you get, switch on and off. You see there? Movements around the mouth, the eye movements, and then he's back again. Back. So it's basically 5-6 seconds and he's out and then he's back. You can actually precipitate these by having the child hyperventilate. So just look at it. Okay. So this is an example of a child, and they're using the old terminology. This would be focal. The child has clear consciousness. And you can see there it starts as focal. But the child is still talking, he's still conscious. So it's a very focal area of the brain that doesn't affect the consciousness. It's got a focal motor seizure, but it's an epileptic seizure. Okay.
Is it my turn? I say one?
This is the old terminology of a focal seizure with suppressed consciousness. You see there? Starts in the eye. If you just touch her, she would not respond. And then she's awake again. You can see the leg there. So this should be a focal seizure, and you can see she doesn't feel well afterwards. Non-epileptic attack. And there are many different examples, but if you would do an EEG, there would not be discharges. So now I want to show you some infantile spasms which occur in which syndrome? West syndrome. Okay. So you see the child is unhappy, she's crying afterwards. It's that sudden jerking movement, almost a dubbing. Okay. Again, sometimes it may be more subtle, like for instance in this child, we will see the child just look at the hands and the head. Just that nod, that was the infantile spasm. You can see that again. And it's easy to see that you can miss that, but the child is very unhappy because the seizure doesn't make him or her feel well. Okay. So I want to show you another absence seizure.
Hi, Tyler.
Hi.
What are we here to do today?
So on the piece of paper to see what it looks like to do in the future.
Yeah, okay. Let's go ahead and start whenever you're ready.
So if you do that for 1 minute and a child does not have an absence, it's usually a very good test. So you don't even need the EEG. You can use one of these little wind wheels to have the child keep that moving and so on. You can see he's still very much in the story. And then you will see the switch going off and then the switch going on again. around the mouth, look at the eye movement, and then he's back again. So it's a big issue if you have hundreds of that during the daytime. It's difficult for you to learn. So it's no laughing matter. So I think it's important that you see seizures and how differently they can look. So some of the things look very much like seizures, but we're not epileptic seizures. And then you can see you get different types of seizures. So the only thing to remember is that the new terminology doesn't talk about complex partial and simple partial. We just say now it's focal, and then we say that the child is conscious, clear conscious, or he's got suppressed consciousness, or the terms may vary a little bit by the time that you finish medical school. They may actually have other terms, but the point is that you describe where in the brain it starts off, and whether the child is wide awake, like that one child that just had the twitch around the eye, but he could still talk, and he could still ask you mathematics, or the other child that was sitting, who also had the focal seizures, but was clearly not there. You can see how absences look, and you will see that once you've really seen an absence, you won't confuse it with just daydreaming and something. It just looks quite different. You can see that the child is not there, and it's sort of an absolute clear break in what is happening, a clear start. Right. So can you press that button for us? Okay. Off, there's something there. Off on.